is a lead in lab. So as we had said, it's a multidisciplinary, Heamophilia is being taken care by multidisciplinary team. We have lab people, we have physiotherapists, we have nurses, we have dentists, we have doctors. Yesterday we had a doctor and a nurse. So today we are having Mr. Hannington Okoth, who is a lab technologist in KNH. He'll tell us how they diagnose the hemophilia. We also have Agrippina Matase, who is a physiotherapist, a trained physiotherapist, and we have a nurse who is a team leader in Heamophilia Clinic. Her name is Marilyn Margai, and I'm Violet Atonya from Heamophilia Clinic. So in case you have a question, please just put it in the chat box. As we start, we shall tackle those questions after the presentations. I now welcome Hannington to take over.
Thank you, Sister Violet. Good afternoon, colleagues. I hope I'm audible enough. Can I get a thumbs up to show me that you can hear me? Am
Yes,
I
we
clear?
can hear. Yes, you are
Okay.
clear.
Okay. Thank you. Thank you. So today's presentation is a continuation of yesterday's series of hemophilia awareness. Today, I want to tackle diagnosis of hemophilia and allied bleeding disorders. I'll uh, I'll be requesting for a screen share. So maybe if you can start from the first slide so that we begin because of time. We have three presenters and we need to give our maximum. So the next slide. So basically, before we do the lab diagnosis, we need to know what happens in our bodies. So we'll have to start with an overview of hemostasis. So with this, just a simple definition is that hemostasis is just a system of checks and balances which involves the vascular system, the platelets, and the enzymatic plasma proteins. These proteins are usually known as the coagulation factors, inactive in our body, and with this, they have to be there is a balance between all these vascular system, platelets, and enzymatic reaction. In case one is not working well, then means there's a problem, and that leads to the bleeding episode that we get from our hemophilia patients. Next. So to understand further, we need to know what happens in our body when we get an injury. So first of all, the first thing which happens is that our blood usually flow in a laminar way, in a laminar flow in the vessel. So once there's a cut or an injury, there's the vasoconstriction. Vasoconstriction is the first which happens where it involves the collagen and the platelets to form a platelet plug. This platelet plug is the primary hemostasis. Once the primary hemostasis has occurred and there's a platelet plug, it's not stable enough. So it will need an assist where we get the assist from the coagulation cascade. So coagulation cascade using the coagulation factors will form a very firm fibrin clot. Hence, we have the secondary hemostasis. Once the clot has stable enough and it's firm, then the healing process happens. And once there is this injured site has healed, there is something called the fibrinolysis and the clot degradation, where the clot is broken down. And but also we need to understand that there is an antithrombotic control mechanism. This one which to balance the coagulation so that one cannot overpower the other. So this is just a brief explanation of what happens when an injury happens in our body. Next. So majorly I'll focus on, because of the presentation we're talking about hemophilia, I'll not dwell much on the primary hemostatic side of it. because it entails a lot. And for the time, I'll just focus on the secondary hemostasis where we have the coagulation cascade. So in the coagulation cascade, first we need to know the coagulation factors. They are 13 in number, given the Roman numbers, and they also have their name, the fibrinogen to the prekallikrein, the factor number 13, fibrin stabilizing factor. So all these are usually inactive in our body. So they'll have to wait for that activator so that they be active to proceed and form a clot. So it's a domino effect where it's one activates the other until we get a clot at the end. So I've given a brief and a simple illustration of what happens in the pathway, coagulation pathway. So I'll start basically in the intrinsic pathway, where we usually start with the surface contact, where we contact usually activate the factor 12 is the high molecular caninogen or the prekallikrein. So factor 13 will be activated to factor 12, sorry, will be activated to 12 activated. 12 activated activate factor 11, and then be activated factor 11. Factor 11 activated activate factor 9, 9 activated. So these 9 activated will need some cofactors. So it will need factor 8, phospholipid, and calcium to activate factor 10 to 10 activated. The 10 activated will join the common pathway. So the common pathway starts from 10 and will need factor 5, phospholipid, and calcium to activate prothrombin, which is factor 2, to thrombin. So this thrombin will activate fibrinogen, which is factor 1, to fibrin. So the fibrin which has been formed here is not stable enough. It will need a factor 13, the fibrin stabilizing factor, which is activated by thrombin, to activate it to the factor 13 activated. So basically, once the 13 activated joins the fibrin, it stabilizes the fibrin from the monomer fibrin mesh to the polymer so that it can be stable enough for healing process. So you will notice there that there are two functions of thrombin. Thrombin activates fibrinogen to fibrin and also can activate fibrin stabilizing factor, which is factor 13 to 13 activated. So basically, that's a flow of the intrinsic pathway from factor 12 to the end, which is the stable fibrin clot. However, it will also need an extrinsic pathway. So the extrinsic pathway is the shortest. It majorly uh, entails factor 7. So the tissue damage tissue factors will activate factor 7 to 7A, and then from 7A it will join factor 10, and then the cascade will just proceed the same way. So basically, we need to understand this pathway so that in case you're doing a lab diagnosis or you get a report from the lab, you will understand which pathway is affected, and you will understand you will see where the pathway is affected. The hemophilia A, which is in the intrinsic pathway. So there is a test which we do in the lab, which always focuses on the intrinsic pathway. So basically, that test, when you do it, is when you will know that the intrinsic pathway is affected. Next slide. So let's go to the lab. Now, what do we do basically? So for us to unlock hemophilia, basically we need lab diagnosis. Otherwise, we might be gazing around, maybe hemophilia, maybe another condition. Maybe there's a problem, another underlying condition that the patient is having, which is affecting the bleeding. So you need a lab test to understand everything. So in our facilities, there are some tests we need to do, the hemostatic test, so that we can assess the cause of the bleeding. Next. So before that, there are some steps we need to do for a complete investigation so that we get a complete report. There's the complete history which is being taken by the clinician. So basically, in our lab request forms, we usually request for a little bit of a history. So doctors, please don't ignore that. That also guides us as a lab technologist in the lab, so that it can give us direction on what we can do further from the request that you've given, and also it gives us a heads up. So give us a little bit of a history so that we can give you a holistic report. Physical examination is also important in that our patients, they bleed in a unique way. It's I know you understand that it's a profuse bleeding from hemophilia patients. So what we do in the lab is that we'll have to do a complete blood count, peripheral smear, and screening coagulation test. So, and then later we can do a specific test to define the nature of the bleeding on the patients. Next, of importance is that all our labs should adhere to some standards for that laboratory test to be significant. First of all, the samples must be suitable for the parameters being measured. We don't want a sample coming in the lab and then we reject. Bring sample which is suitable, enough, right vacutainer, not hemolyzed, not clotted. Those are the samples that we need. And then also it should come at the right time. The test also should be properly regulated. We need to have a standard SOPs as lab technologists that we need to have a procedure in place, and all our tests has to be quality controlled, both internally and external QCs has to be adhered with. Sample management. Once you get the sample, good quality results will always depend on the quality of the sample. The anticoagulant of choice is basically the 3.2% sodium citrate, and an EDTA is used for a full screen. For EDTA, we do for hemogram and the PBF. However, on the sodium citrate vacutainer, there is a ratio we have to maintain where it's 1:9 ratio, where one part is the anticoagulant and 9 parts of the blood. So this one is usually attained on the vacutainer. It's usually there's a black mark indicated because our vacutainers are commercially prepared. So the manufacturers usually give us a mark. So always adhere to that. So make sure that your sample reach at that level for us not to reject it. However, we've just given a slight disclaimer that anything less than 90% we'll have to reject because I understand the nature of our patients. Somehow we need to get maybe other investigations need to be done, difficult in getting blood in the patient. So sometimes we give an allowance which cannot interfere with the report. So anything less than 90% will reject. And all hemolyzed samples we have to reject at closure. So we also encourage that you get your sample from straight vein, not get it from the bucket, the granulars and the indwelling catheters placed on the patients. And also we should minimize tying a tourniquet for long. So it should be under 1 minute. Look for vein and be sure that you go to the right vein is when you tie your tourniquet. Next. So indwelling catheters are avoided. I've talked about that. When you get your sample, mix it gently. Don't mix it vigorously, or you might activate platelets and the clotting process might start. So just mix gently, making sure that it doesn't clot. Now our samples need to be analyzed immediately. So we usually encourage coagulation samples to reach the lab within 4 hours, to be analyzed within 4 hours of sample collection. So once you get your sample, make sure that it reaches the lab immediately so that the analysis can be done within 4 hours. However, if you feel like you cannot do it within the stipulated time, there are some procedures you can do. That's in the next slide. So we can do either sample transportation to the nearest laboratory where we can analyze, or we can keep it in our freezers for further analysis in case you are doing large quantity investigation, you're doing a research, there's that batching of samples. So what we do first, we have to separate the plasma. We spin it at 3,000 revolutions per minute for 10 minutes. And then we transfer the plasma, which is the platelet poor plasma. The reason why we give it 10 minutes is because we need that plasma to be, it should not have any platelets. and then you transfer it in a plastic screw cap, the Epidoc tubes or the cryovials. If you are going to do it later, for longer storage, advocate for -80. Immediate, maybe not longer storage, -30 works until the analysis or transportation. However, on transportation, for long distances, we advise for dry ice and liquid nitrogen for transportation. That's a challenge. We'll discuss on that, but you can use ice if you are short duration for transportation within 1 to 2 hours. Do not store your plasma in at fridge temperature of 2 to 8. So please, if you feel like you're not doing the sample immediately, just freeze it. Don't keep it at 2 to 3. So when we come to the lab, there is a screening test that which is being done. So the screening test is usually the preliminary procedure to detect the most characteristic sign of a disorder that require further investigation. Number one is the prothrombin time, normal in our hemophilia patients. If abnormal, just check your QC. If there's a problem, LFTs, maybe the patient has a problem with the liver. APTT is the gold test that we check on hemophilia patients, usually abnormal, means it's prolonged. Thrombin time or fibrinogen assay, which checks on the common pathway, usually normal. CBC, we check to check on the low RBC, HB, and platelets to check if the patient has been bleeding for long. And then, of course, we need to do mixing studies, factor assay, and inhibitor testing. Next. So the first test we do is the prothrombin time. This test usually measures the time taken by the situated plasma to clot in the presence of a tissue factor and calcium. That's the principle at which the test acts on. It usually tests the extrinsic pathway. So what happens is that the tissue factor will activate the extrinsic pathway by activating factor 7, and it goes onwards. Normal ranges between 11 to 16 seconds, and PT usually abnormal in all those label named there, bleeding liver disease, if you have any abnormalities in the pathway. Next. So these are just a continuation where I have explained that the INR. INR usually normal in our hemophilia patient, the same as prothrombin time, but INR is a ratio, international normalized ratio. We calculate it from the prothrombin time. So basically INR mostly it's used for our patients on warfarin monitoring. So calculation takes into account the sensitivity of the reagents to the effect of the warfarin on the extrinsic pathway. So on your left, you see the INR, the patient, the PT of the patient divided the PT of the normal range, and then you raise to power the ISI, the International Sensitivity Index. This one we usually get it from the kit inserts of that reagent. How sensitive is our reagent? That's what we use to calculate the INR. Next. So if you check on the pathway, those are the factors involved in the extrinsic pathway. So if you get a prolonged PT, just bear in mind that all those factors can be involved. Next. I'll go to the gold test, which is the APTT. Uh, Basically, this test usually checks on the intrinsic pathway. It's usually the time taken by a situated plasma in the presence of a negatively charged contact activator, which can either be silica, kaolin, ellagic acid, combined with a phospholipid, which is the partial thermoplastin, and calcium chloride. So basically, that's the principle and what we do in the lab. The test we do is based on that. And then this is usually, if prothrombin time is normal in our hemophilia patients, an abnormal APT usually indicates deficiency in factor 8, 9, and occasionally maybe 12 and 11. Next. That's what we do. On your left is a test tube presenting on what we do. We usually take the plasma, add the activator and phospholipid incubate, add calcium, and then we check on the time it takes to clot. It demonstrates the intrinsic pathway, the factors involved in the intrinsic pathway. Normal ranges is between 25 to 35 seconds. And our abnormality is usually due to those factors involved. There are those pathway, any bleeding, liver disease. Those who are on heparin, the therapeutic patients who are on heparin, APTT is used to, as a test, used to monitor that. Of importance, always note that the APT is abnormal in our hemophilia patients. Right? And that's it's a diagrammatic representation of the factors involved. All those factors will make our APTT increase. So I've not discussed about tests used to assess the common pathway. We can use fibrinogen or the thrombin. My main aim was to discuss on those two so that PT will discuss on one pathway, APTT will check on the other side. So I'll just go to mixing studies and factor assay because of time. Next, I'll start with the case studies. This is a boy, 2-year-old boy, who came to an emergency department as being evaluated for bleeding, and a sample was sent to the laboratory for coagulation profile. The results came as a PT of 13.7, and I gave a normal range, which is normal, whereas the APTT was prolonged, 82.5. Normal ranges is between 24 to 35, and a control of 30. That shows it's really prolonged. So basically, what we do next is our mixing studies. We need to know what is the problem with the APTT. So in the mixing studies, next slide, we do, it's called mixing studies, correction studies, or substitution studies. Either can work. It means one are the same thing. So an abnormal APTT is followed by mixing the patient plasma and normal pooled plasma or a normal control in the ratio of 1:1 and an APTT done to check if it's a factor deficiency or an inhibitor leading to the abnormal result. So what happens is that when the patient plasma is mixed with the NPP, uh, if APT does not get normalized or it doesn't correct, doesn't come from the 82 to lower next to the normal ranges, or if it doesn't correct to less than 50%, it indicates the presence of an inhibitor. However, if it corrects with greater than 50%, then we conclude there's a factor missing in the patient. Because what is missing in the patient, as the patient has received, the patient plasma has been corrected with the normal plasma, because normal plasma has all the factors. So what we do is that similar tests is performed with specific factor deficient plasma samples to check on which factor is missing. So basically in the lab, we usually have a commercially prepared, or you can also prepare it, in the lab, a factor 8 deficient plasma and a factor 9 deficient plasma. And then you do similar mixing studies. Right? So when you get this patient, I'll describe that with a diagram, with that table. So on your left, there's a deficiency, which is factor, it's either 8 or 9. So when you do the APTT for those two, you'll get them abnormal. But if you mix with the normal plasma, there's a correction. However, if we focus on factor 8 deficiency, we mix with the factor 8 deficient plasma, there'll be no correction. But if there's a factor 8 deficiency and we mix with factor 9 deficient plasma, there'll be a correction. So this patient doesn't last factor 8, and the deficient plasma doesn't have factor 8. That's why there is no correction. So that one we can conclude that is a factor 8 deficiency. So when you go to the lower side, it's a factor 9 deficiency. Both APT will be abnormal, normal full plasma will correct. Factor 8 deficient plasma will correct because the factor 8 deficient plasma will have factor 9. That's why it corrected. However, if you mix with the factor 9 deficient plasma, there will be no factor 9 in that plasma. And also the patient doesn't have factor 9. That's why there's no correction. So basically, this is just an explanation of what we do. But in the lab, what we'll give you out as a report for the clinician, we'll give them in seconds. So basically, you analyze, does it correct or it doesn't correct based on the initial APTT report. Next. So this one I've given an explanation giving in seconds. So check on your left an example of an APTT mixing study. So the NPP, the normal pool plasma, when we do an APTT, it came at 32 seconds, which is within the normal ranges. The patient was at 96 seconds, which is prolonged. When I mix with the patient and the normal pool plasma, it gave a 31. That means there's a correction. It came from 96 to 31. A very good correction. When you mix the patient and the factor 8 deficient plasma, it gives us a 92. It means it has stayed up, it's still prolonged. So it has not corrected. But when you do it a factor 9 deficient plasma, it has come to 37. It means it has come from 92, 96, and it has corrected to 37. So in our conclusion or in our report there, we'll write a factor 8 deficiency for that patient because it didn't correct with a factor 8 deficient plasma. The patient is missing factor 8. So on the right is an alternative way of how to just understand this. This is just for understanding purposes. Basically, this is what happens in the patient themselves when you infuse the factor 8 or factor 9 concentrate. So what happened? The patient, these are demonstration on the left. The patient 32 seconds, the NPP 32, the patient 96. So when this patient was given a factor 8 concentrate, check on the factor patient plasma and factor 8 concentrate, there's a correction from 96 to 37. So it means they're responding to that factor 8 concentrate. Then diagnosis is a factor 8 deficiency. So the right side is just to make you understand what is on the right, on the left. Next slide. So once we've known that the patient is missing a factor 8 or factor 9, the next stage is we need to do a factor assay, the quantification. What is the level of factor in the patient? So factor assay is these are one-stage APTT. The principle says that it's based on I think I'll just explain it in a simple layman language in that this is what we do in the lab. I mix serial dilutions of the patient and the reference plasma, which is the normal plasma, and I combine with factor 8 or factor 9 deficient plasma, and I do an APTT and I'll draw a graph. So on that graph, this is how we calculate and check on the quantity in the patient. This is the manual method of doing APTT. However, nowadays we have a fully automated analyzer which is making it easy to do this one. So this is just a factor assay procedure. Next. So in our reporting, we'll only give you the report on the efficiency levels where we have a mild hemophilia, which is between 5 to 50 or either factor 8 or factor 9. Moderate is 1 to 5%. And a severe hemophilia always have a less than 1% of factor 8 or factor 9. Next. So basically, once we've diagnosed our patients, they'll develop inhibitors later in life. So inhibitors are generally suspected in patients having prolonged bleeding episodes who do not respond well to the factor replacement therapy. So we do a screening. Is recommended for any patient who has hemophilia, who are going for surgical procedure, or if they are having prolonged bleeding after giving the treatment. Next. So inhibitors we just do is a simple test. We have the screen where we mix patient plasma and normal plasma and check the APTT. So if it's still abnormal, we further incubate at 1 and 2 hours for factor 8 because factor 8 is a long-acting inhibitor, or 15 minutes for factor 9. And then we read to check the incubated mix and the immediate mix. So if the APTT reading of the incubated mix is still longer than the immediate mix, it indicates the presence of an inhibitor, which is subsequently confirmed by a Bethesda assay. Next. So the Bethesda assay is the quantification of, we check how aggressive are the inhibitors. So a positive inhibitor screen leads to the Bethesda assay. It's a very long procedure which cannot be described right now. So the report is usually high titer inhibitors are usually anything above 5 Bethesda units per ml. Low titers is usually less than 5 BU per ml. Next. And basically that's where I want to end because that's where we have finished diagnosing our hemophilia, and also in case they develop inhibitors, we can know and which treatment can be given the patient. So basically laboratory diagnosis is a bleeding, of a bleeding patient follows a stepwise assessment using tests that assess the integrity of different aspects of hemostasis to arrive at a conclusion. So in case there is an unexplained abnormal coagulation test, please don't just give the report. Request for a fresh sample and repeat the test. So, because this one is an accurate diagnosis, the beginning of proper management of the patient. All the patients we've diagnosed early in life usually have a normal life. They don't have all the complications patients who have got a diagnosis later in life. And knowledge and expertise on coagulation is crucial for personnel running those tests, and quality assurance is absolutely essential. So thank you, and I think that will be the end of my presentation. Back to you, Sister Violet.
Thank you, Hannington, for that presentation. Please, if you have any question, put in the chat box. He'll just answer your question after the presentation. Now we have seen how lab people are very important in the care of hemophilia patients. Now let's see how physiotherapists again come into that care. I invite Agrippina Matasia for the next session. Welcome, Agrippina.
Good afternoon, all of you. Thank you for making time to come for this webinar. My name is Agrippina Matasio. I'm a physiotherapist at KNH. Outpatient clinic is where I'm stationed. And I also oversee the hemophilia clinic in the hospital. I attend to patients and also I mentor other physios in the management and role of physiotherapy in hemophilia care. So today we are going to look at what is the role of physio in hemophilia care. Okay. So a disclaimer is that most physios usually are afraid of seeing patients with hemophilia because bleeding tendencies role to play because the so sorry for that. So most I have a disclaimer because most physiotherapists have usually have fear of seeing hemophilia patients because of their bleeding tendency. But we've seen that physiotherapists play an important role in the care of hemophilia patients. And today we are just going to give a brief sensitization on how we can be part of this team in the management of our patients. So hemophilia is a genetic disorder characterized by deficiency and absence of certain blood clotting factors, which leads to prolonged bleeding episode. I think those who attended yesterday's webinar, the doctor was able to, and the nurse were able to explain how this happens. So this is our comprehensive care team. I usually want to show this slide because we are a team. We work as a team, and physio is a musculoskeletal expert in the management of hemophilia patients. So we are patient-centered approach is key to the management of hemophilia. So physio plays a crucial role in treatment and management of hemophilia by focusing on maintaining or improving joint health, muscle strength, and basically seeing the overall physical function of the patient. How do we do this? We do assessment and evaluation, we do treatment, and also we do patient education. So this is a clear picture or what we come across when we see patients with hemophilia, and it can be very confusing when it comes to management or also when we are diagnosing, because it mimics other other diseases or like septic arthritis. So hemophilia also leads to joint and muscle bleeds, which can result in pain, stiffness, and reduced range of motion for the patient. So I was just showing typical pictures that you find. These are muscle bleed. The patient can bleed in any muscle, the thigh muscle, the back muscle, anywhere when they get injury or spontaneously. Also, there are other complications like joint destruction, and then muscle contractures, and also nerve damage. This comes about because of bleeding, because sometimes when they bleed so much, there is a compression on nerves and it can cause nerve damage. So for physiotherapy intervention, we do things like joint mobilization, range of motion exercises, and proprioceptive training, which helps to maintain joint health and prevent complications such as contractures. And this also improves the flexibility of the muscles and the joints. So in muscle strength, we make sure that these patients have strong muscles. We give strengthening exercises, which are essential for individuals with hemophilia to support the joint stability and prevent injury. And also, as physios, we design tailored exercise programs to strengthen muscles around the affected joint without causing excessive stress to or risk of rebleed. So our exercises are usually patient-centered and also patient-tailored. You cannot give all the patients the same exercises. So after assessment, we're able to give individualized exercises, and you'll see the considerations we have in the next slides. So we also look at management of pain. We use various techniques such as manual therapy, modalities like cold or heat, ultrasound, and exercise prescription in the management of pain associated with hemophilia-related joint bleeds and musculoskeletal complications. As we're working on the joint range, you don't forget about balance and coordination training, because that is part of the role of a joint. So hemophilia can affect the balance and coordination due to joint damage and muscle weakness. So physiotherapy intervention focuses on improving balance, proprioception, and coordination to reduce the risks of falls and injuries. Under education and prevention, we do a lot of education to patients and their families and caregivers about hemophilia. To participate in school without harming themselves. Then following bleeding episodes and surgical intervention, physiotherapy plays the previous one. So we also, following bleeds and bleeding episodes and surgical intervention, we as physios play a crucial role in facilitating recovery, restoring mobility, and regaining functional independence for the patient. We also work closely with other healthcare providers to coordinate comprehensive rehabilitation programs tailored to individual needs of the patient. So some of the special consideration that we look at as physios are assessment and screening. So before initiating any physiotherapy intervention, it's crucial to perform a thorough assessment of the patient's condition, including their joint status, muscle strength, range of motion, and any existing bleed. So our assessment, the first assessment should be very thorough, so that you have a baseline of where you're starting with the patient. Then another consideration is individualized treatment plan. We have intervention to be tailored to each patient's specific needs and condition, not doing a blanket intervention for this patient. So they should be very specific and to the patient's need. So another consideration is joint protection. We find that when the patients are in acute bleed, we make sure that the joint is protected for them to be able so that we can avoid risks of developing other bleeds. So patients are at risk of bleeding, even in the joint, even during exercises and even in other subsequent joints. So we have to make sure that those joints are protected. So our emphasis should be on techniques that will protect the joints, such as good body mechanics, avoiding high impact activities, and using protective gears when engaging in physical activities. Then we also encourage low impact exercises such as swimming, cycling, and walking, which can improve cardiovascular health and overall fitness without putting excessive stress on the joints. On pain management, most of these patients are usually in a lot of pain, and that pain is usually can be until it's chronic due to joint damage and repetitive bleeds. So the physio can incorporate pain management techniques such as ice therapy, mild heat, ultrasound, some of the techniques we use for other patients. But for hemophilia patients, we have to really be specific. And then under education and training, we educate our patients and caregivers about the importance of adhering to treatment plan and recognizing signs of bleed and implementing appropriate first aid measures. Because we realize that if these patients and caregivers are not aware of what they are supposed to do, we increase the risk of the patients developing complications at an early age. And then another consideration is we communicate with other in the healthcare team, collaborating closely with patients, healthcare team, including hematologists or any other team member in the management of hemophilia. We coordinate each other so that we are on the same page when we are managing these patients. So under monitoring and supervision, our patients, we usually supervise them in our exercises. So these are patients we not just give an exercise and leave them to do alone. We have to make sure that we are monitoring how they are doing their exercises, how they are responding, to adjust when there is need, and also to make sure that they are doing those patients to ensure safety and proper techniques. And then as physios, we have to be prepared in emergencies, because sometimes you can do an exercise for a patient and cause a bleed and injury during physiotherapy session. So we are careful in making sure that the patient, if the patient bleed, what's next? We have to prepare ourselves for any emergencies. And have appropriate medical equipment and know how to respond promptly and effectively in case of a bleed during a session. We also recognize that these patients go through a lot of psychological stresses. So as physios, if a patient is stressed, then they are not able to do the exercises. So once you recognize that the patient has some stress that they are not able to adhere to their program, we provide support for the patient and their families and address their psychological factors such as anxiety, depression, which when we send them for therapy, we're able to improve their overall well-being and adhering to treatment. Next. So one of the things we do is first aid. When a patient has an acute bleed, as physios, our first treatment is first aid. And the acronym we use is PRICE. We do preventive measures. And then preventive measures include the patient not putting load on that joint. So we want them to rest, and then we do icing. Icing should be done not directly on the skin of the patient. So we put ice and you wrap crushed ice in a small towel, put in the area in the joint that is bleeding, 5 minutes on and 10 minutes off, because we realize that when you put ice on an area for a long time, it does the reverse. So this is the education we also give the parents or the caregivers, so that by the time they're reaching hospital, they have done some first aid on the patient. So then we do compression and elevation. So this is basically the first treatment we give patients when they have acute bleeds. So we should not be scared of seeing patients when they are in acute bleeds, because we have a role to play as physiotherapists. Under joint protection and immobilization, immobilizing the affected joint through splinting and bracing can help prevent further damage and promote healing. But however, immobilization should be limited to acute phase only. Once the bleed has started to resolve, the patient is supposed to start having some joint movement, some exercises, free active exercises within the limit of their pain, so that the muscles are able to start activating to prevent long-term weakness of the muscle. So we also use assistive device to offload weights, e.g. crutches. If a patient has a knee bleed, one of the joint protection is making sure that they are offloading their weight on by using crutches on. Maybe sometimes, usually we start with non-weight bearing. As we progress to partial weight bearing, as the patient's bleed is subsiding. So we know that evidence-based practice is important. So we have tools that we use for our examination, so that we are able to have good outcome and also do research on in our institutions. So some of the tools that we use for hemophilia patients are, and these are international tools we use, which have been developed by World Federation of Hemophilia. So we have the World Federation of Hemophilia Physical Examination Score, that is Gilbert score. We have the Hemophilia Joint Health Score, and then we have Functional Independence Score in hemophilia, and then we have a hemophilia activity list for pediatrics, but there's also for adults. So these are some of the tools we can use to do assessment and of our patients, and also evaluation as we go along our treatment plans. So in conclusion, overall, physio is an integral component of multidisciplinary care for individuals with hemophilia, aiming to optimize physical function, enhance quality of life, and minimize the impact of the condition on daily activity. We want these patients to live a near normal life. So collaboration efforts between patients, caregivers, and healthcare providers and physiotherapists are essential for effectively managing hemophilia and promoting overall health well-being of the patients. And that is the end of the short presentation. Questions can be put in the Q&A and chat box for later response. Thank you.
Okay, thank you, Agrippina, for that presentation. You have now seen how important physiotherapy is for the care of the hemophilia patients. Now we are going to see how nursing is essential for them. And I'm not campaigning for a nurse, but even I have it. The nurse is the key person in the care of this patient. When the patient comes, he'll meet the nurse, and when he leaves, he'll leave in the hands of the nurse. So let's give Marilyn this time to tell us how they manage the hemophilian patients. Welcome, Marilyn.
Good afternoon, everyone. My name is Marilyn Margain. I'm a nurse working at the Hemophilia Clinic. We've gone through the diagnosis, we've gone through the physios. Yesterday we went through the hemophilia management and the bleeding in women and ladies. So today we're going to look at the role of the nurse in the hemophilia care. So as Bayo has already said, nurses usually play a very crucial role in managing hemophilia. And this includes education, treatment, adherence, pain management, and promoting joint pain as we work in collaboration with the physiotherapists, while also ensuring that emergency preparedness and collaboration with the other team members whom we work together. So we're going to look point by point on what we're supposed to do in managing hemophilia. So in nursing intervention, we start with assessment. When a patient comes, we have to look at this patient. You assess and look at the location where the bleed is. Yesterday's teaching, we were told that hemophilia is the main manifestation of this disease. So when a patient comes limping, you have to assess this patient, the location, the characteristic, and even the rate of pain, and then you manage accordingly. And then you also assess for the swelling and whether this patient is also able to use this thing. If this patient is not able to use this thing, because you are the one who is there at that point, you have to immobilize the limb. And in collaboration with the physiotherapist, this patient will apply an elastic bandage at the affected joint, elevate it, and also do the rise that the physio has already mentioned. So immobilization will promote comfort and decrease in the joint damage and even the pain, and also reducing the bleeding. Elastic bandage will reduce the mass of bleeding, and elevation will also minimize the swelling. So we can also provide a bed cradle for this patient, especially for the painful joints, because if something like a blanket lies on it, these joints are usually very painful. And also, if a patient has to go for physiotherapy, they should not be in pain, in acute pain. The pain should have subsided for the physio to go on with their work. So as we continue with our intervention, we have to administer medication to this patient because this patient has come in pain. So the medications that we normally give to this patient include acetaminophen, which is paracetamol. Usually we give them IV. We also give drugs like morphine oral, which we normally stock at KNH clinic. We do not give NSAIDs. NSAIDs are contraindicated. The other thing we do to manage this patient is replacing the deficient factor. If it's a patient who's coming with hemophilia A, we will replace with factor 8. The other thing we normally do to this patient, which is our role, is to educate these patients. We educate the parent, we educate the child. And by educating them, we need to tell them how this pain came about. They need to tell us first, as we take the history, how it came about. At times it comes up spontaneously. So we'll educate them depending on how this mother has told us. Maybe he left the child to play so much until this child fell and got a bleed in that limb. So we'll try to educate this patient and the mother on how to take care of themselves at home. The other thing is also to instruct the child on how to walk when they have a limb that is having a bleed. And usually they are given devices at the physiotherapist, which will aid them to walk around with the crutches. So the other role of nurses is during pre-operative preparation. At times we have patients who need to go in for surgery, like circumcision patients, or any other surgery that these patients may require. What we're supposed to do is to ensure we ascertain the hemophilia type of this patient, the severity type, confirm also the details of this patient, whether they've been on prophylaxis, the dosages, and how often they've been getting. You should also do an inhibitor screen to these patients, and we should also do the routine blood works, ensure that they are done. And we can also repeat a coagulation profile for this patient to just be sure that this patient is hemophilia A if he's claiming to be hemophilia A. The other thing is during the intraoperative care, we should ensure that these patients receive factor immediately just before the surgery, usually 30 minutes before surgery. And the dosages are usually calculated using the formula that we're going to look at. It is the weight times the kg times 0.5, that is if it is factor 8. So 20 minutes after replacement, the factor level should be rechecked in ideal situations, and then additional doses of missing factor will be given intraoperatively. So with the lab results that you have, replacement of the missing factor percentages is usually done during surgery so as to top up the blood factor activity to 100%. During the pre-operative, post-operative care, we continue with replacing the factor every 8 hours for hemophilia A and usually 12 hours for hemophilia B. And then we'll continue with daily factor measurements to continue the levels at least at 30% for the next 2 to 3 weeks. So that is what is recorded in that chart below. So as we continue with the management post-operatively, we should ensure that these patients are pain-free. So pain management should continue even post-operatively until full recovery. Pain management starts usually with strong opiates like morphine, and then we go towards the less strong one like the tramol. Then as we continue assessing, we'll go to probably paracetamol and even meloxicam. Normosavulan irrigation of the sites before any dressing change, so that this dressing will soak before it is removed, so that we avoid any bleeding at the site. Then topical application of antibacterial cream should be applied to these raw areas so that we may promote healing in these patients. So in case of bleeding, dressing should be done with a light gauze. And also ice pack management should also be continued. In case we have a patient who's gone for circumcision and they're having erections, we usually use the ice packs so that we avoid bleeding. So in case a patient has inhibitor and they are post-operative, they are usually started on fiber, factor 8 bypassing agent. So this will be administered until this patient is out of danger and until this patient is discharged. So when we look at the calculation on how we're going to calculate factor, this was learned yesterday, but we're just going to rush through it. We usually calculate using the international units. So in factor 8, usually 1 international unit per kg factor 8 raises plasma level by 2%. And if a patient has come in with a minor bleed, will give around 20 to 40%, 40 to 60%. If it is a major bleed, will give between 60 to 80%. The half-life of factor 8 is usually 12 hours. In factor 9, 1 international unit per kg factor 9 usually raises the plasma level by 1%. And if this patient comes in with a major or minor, we said 40 to 60, major we said 80 to 100. And the half-life of factor 9 is usually 18 to 24 percent. These are some of the clotting factors that are available at KNH at the Heamophilia clinic. This is alcoholic, this is factor 9. They come in different doses. They can come in 250, 500, 750, depending on how much you're supposed to give the patient. You can either combine, if the patient is to get 750, you can combine 500 and 250. If a patient is to get probably 1500, you can combine 1500, depending on the availability on whatever you have is what you're going to give your patient. And this is how we normally assemble these factors. They come already with every accessory that we need. There's powder, there's a diluent, there's a needle and a syringe. So you're able to just mix like any other drug, and then you just push, do a slow push. You don't give these factors subcutaneously. They're usually given IV. If you give intramuscularly, these patients are going to get intramuscular bleeds. These are some of the factors that are also available at KNH. Then we're going to look at the family tree. Family tree is also at times called genealogy. It's also called genealogy. It is a chart that is representing the family relationships in a conventional tree structure. So it is usually drawn for every patient that is seen by the hemophilia nurse, and it should cover at least 3 generations. All the information should be printed clearly and must be in a large position, and it has to have a patient name, type, hemophilia, hospital number at the left-hand side corner. And this is how we're supposed to draw that family tree. You should have a key at the bottom left hand corner of the page. Then you start the index sketch, draw a square, coloring it black with an arrow. Then carriers put a circle. That is a patient who is a carrier. You put a dot. For the male without hemophilia, you draw a square. This is an unaffected male. If it's a female who is not a carrier, you'll draw just a plain circle without a dot. If this patient is dead, you just cross in the square or the circle, depending on the gender. And this is an example of a family tree that we normally carry out at our clinic at KNH. Thank you so much for listening.
Thank you, Sister Marilyn. We have now come to our end of our presentation. Let's see if you have any question, please put on the chat box. We are going to tackle them now. There's only one question where they have asked if the it's CPD aggregated. Yes.
For the forest for the lab, we are following up through the board.
We are following up through the board. That's a lab. That's from a lab person. So we are following up with the lab. There's another question. Can we have slides from today and yesterday's, please? Yes, they're available.
We will share the recording.
We'll share the recording. Any other question? Okay, thank you so much for everybody, for those who have participated in this webinar. I take this opportunity to welcome you all. This being our month of celebrating our World Hemophiliac Day, we welcome you all on 16th, next week, Wednesday, at KNH for the celebration of our World Hemophiliac Day. And we shall be having a screening of new patients. We shall be doing family tree tracing, and we shall have testimonies from affected patients. And on 17th, on Thursday, we shall have a major World Hemophiliac Celebration Day at Muranga, and we welcome you all. Another thing I would like to request our participants, please, we were taught yesterday there between out of 10,000 people, one person is hemophilic. And in Kenya, we have 55 million people. And we expect to have 5,500 hemophilia patients. And we have not gotten a quarter of them. Please assist us to get these patients. They are suffering outside there. Besides getting the knowledge, let's have these patients being screened so that they can be identified. Otherwise, I wish you a good day. Thank you so much.
Yeah.